Hey, Jeremy.
Steve?
Why are you looking so blue?
Diabetes is just kicking my butt today, man. I'm high, I'm low, my time in range is like 2%. I've just had it with diabetes, man.
I'm sorry, buddy. I've been there. But you know what I try to remind myself of?
What's that?
That there's never been a better time to have diabetes, type 1 and type 2.
What do you mean?
Oh, man. In the last 10 years, look at the advances. Continuous glucose monitors, hybrid closed loop, better insulins for people with type 2, oral medications, and others that help protect their heart as well as improve their diabetes. You know what? People 50, 60 years ago, they couldn't have even dreamed of having these things.
Hey there, Mac. Yeah, you. You have a touch of the sugars? Why, of course you do. Well, why not do something about it, pal? What's new with glucose monitoring, you ask? Why, everything, of course. Cheer up there, mopey man. Gone are the days of just wondering what your sugar level is. That's right, pal. We now have urine testing. The splashing means it's working. Out of sight. And who knows what the future will hold? Testing your blood sugar? You heard me right. It's just around the corner. Getting a blood sample is easy as pie. With just under 1 pint of blood, you can get a result by this time tomorrow morning. Science. Still not convinced? How about a continuous glucose monitor? We're telling you folks, this is the absolute latest and greatest in diabetes technology. And her name is Myrtle.
Check your blood sugar.
Day or night, Myrtle will help you monitor your blood sugar every 5 minutes.
Check your blood sugar. Check your blood sugar. Shh. Check your blood sugar.
Godspeed, Myrtle. What about new medications? That's right, folks. We've got both of them. The pill and the shot. Looks like you've met your match, diabetes. Those insulin injections got you down? Well, check out the latest in insulin pumps. Cannonball! Better start eating, mister. That was 500 units of pure bovine insulin. Fantastic. And last but not least, we have the latest advance in diabetes tonic. That's right, patriots. It's Dr. Edelman's famous diabetes tonic. Guaranteed to put hair on your head, some pep in your step, and diabetes on the run. And don't forget, folks, Dr. Edelman's tonic is used by most leading psychologists to treat the blood sugar blues. Hey there, Bill. You know that's just bourbon, right? Act now before Bill drinks it all.
Wow. Steve, thanks for that informative and hilarious perspective. We really have come a long way.
You're right, Jeremy. There have been so many advances for people with type 2 diabetes. I'm going to do a session on it right now.
Hey, everybody. We're going to talk about the type 2. Eric, do I have to wear this?
Nope, sure don't.
Okay. We're in a room. We're socially isolated. Hello, everybody. I'm really excited to tell you that there has never been a better time to have type 2 diabetes. Now, this is sort of a summary of my 40-minute lecture. Okay, let's talk about the first one. Believe it or not, we have 12 different classes to treat type 2 diabetes. We have newer medications that not only lower your glucose, but also improve your risk, lower your risk factors for heart disease and protect your kidneys. We have several medications that help control your weight and do not cause hypoglycemia. And that's very nice characteristics compared to some of the older medications. And we have newer ways to treat hypoglycemia. The medications are much easier to take and have less side effects. For example, we have weekly medications now. And very importantly, what's the most important message for today? Here it is. Get type 2 diabetes, control it, and live longer because of it. That's the bottom line. Now, it wasn't that long ago that people were saying, what is type 2 diabetes? Oh, it's just a touch of sugar. And they were not taking it seriously. But it turns out that both type 1 and type 2 diabetes are very serious conditions, especially if you don't take care of them. And they don't have to be serious if you can control them. Now, I'm not going to read to you all the things on this slide, but my main message of this slide is that one of the most common causes of passing away when you have type 2 diabetes is heart disease and stroke. That's why I'm going to talk about cardiovascular risk reduction in my presentation today. It's key. It's extremely important. Now, I want the rest of you folks out there that do not have diabetes, don't feel left out. What's the most common cause of death in anybody in the United States? It's heart disease, but the risks are a little bit higher if you have type 2. And what's also important to tell you is that the risk factors for heart disease are definitely controllable. Okay. Now, this is a map of the United States. Now, you can notice here that this is 1990. In the states in black, we don't have any information. The states in red, you can see 6% of the population have diabetes, and there's different shades of blue. Now, you ready for this? This is 2020. Now, every single state is red. Now, not only just the regular red, a darker red, which means that over 10% of the population has diabetes. Mostly type 2, but that does include type 1. So it has become a worldwide epidemic, not just in the United States. Now, believe it or not, over 6,000 people are diagnosed with people every day. Now, I'm from San Diego. We had the San Diego Chargers here. They went to LA, those sons of, no, I won't say it. But when they were here in San Diego, we packed the stadium. Take a look at this picture. In the year 2050, it's estimated that 1 out of 3 individuals will have type 2 diabetes if the rates continue as they are continuing today. And who knows, it may continue faster, it may continue slower. Now look at all the people. That's 1/3 of that stadium. Now here's the question for you. Will the sales of candy go up in that section, or will they go down? Think about it. Okay. Now, what about Tom Hanks? He's one of the most recent movie stars to get type 2 diabetes. And the thing about type 2 diabetes, it crosses all socioeconomic boundaries. No one is protected. Now, believe it or not, 90 to 90% of all people with diabetes have type 2, usually heavy. And I'm going to talk about abdominal obesity in a second. Extremely important. Usually diagnosed after 35. Now, underscore usually. In diabetes, never say never, never say always. The cause of type 2 diabetes, we don't know exactly, believe it or not, but it has something to do with this word insulin resistance and many other defects. What is insulin resistance? The insulin that our bodies produce do not work very well to get the sugar out of the bloodstream into the cells of our organs for utilization. So if they can't get into the cells of our organs, it stays in the blood and it stays high, and you have type 2 diabetes. And many of the medications I'm going to talk about are geared around the defects seen in type 2 diabetes. So it's much higher risk in ethnic groups: Pacific Islanders, African Americans, Latinos, and Native American Indians. Extremely high rate. Why? It runs in the genes. And that's something that we don't know the exact answer to as well. And then the other thing that's important, what else is related to having diabetes? High blood pressure, abnormal cholesterol, and heart disease. So when you treat type 2 diabetes, you have to think of the heart. That's extremely important. And That's why there's never been a better time to have type 2 diabetes, because we're going to talk about medications that do both lower glucose, lower your A1C, and reduce your risk factors for heart disease. So here are the ABCDs of diabetes. Just used to be ABCs. A is aspirin, if your caregiver says you're an appropriate candidate, and A1C, which is glucose control. B is blood pressure, C is cholesterol, and D is drugs. Medications that protect your heart and your kidney. I want to make a big deal out of this, so hopefully you don't get too tired of me saying it multiple times. Now, what goes without saying is slow, realistic lifestyle modification. And we have lots of other lectures in our video library, on the on-demand section, other webinars with our dietitians that know a ton about lifestyle and how to eat, and exercise physiologists. So when we think about what some of the unmet needs are in type 2 diabetes, what are they? Preventing and controlling weight. It's so easy to gain, so tough to lose. And I think all of you folks with type 2 is probably one of the highest on the list. It's just the weight. And your family members probably give you a lot of grief as well. High rate of heart disease, and we'll talk about that as well. Difficult to make long-term lifestyle changes. Very hard, because most people get type 2 later in life. How do you change the things that you like to eat and like to do? Adherence to medications. I'm going to talk later about type 2 diabetes being a polypharmacy condition. No one likes to take a handful of pills and shots every day. And the emotional burden of type 2 diabetes. That's why we have Bill Polonsky, our touchy-feely guy. So you'll have to check him out, other lectures for today's program and past programs. So let's talk about weight. This is probably the best quote I ever received from a patient. I could smell food and gain weight. And it's always amazing to me why it's so hard for people with type 2 diabetes to lose weight. Believe it or not, much harder than other individuals that do not have type 2 diabetes, but are on the same, that weigh the same and eat the same exact caloric restricted diet, doing the same exercise. People with type 2 diabetes do not lose weight as easy as others. And here's a picture of what we call in medicine central or abdominal obesity. And we talk about the waist to hip ratio. And it's more of the apple shape versus the pear shape. Now, I'm going to show you on the next slide an MRI. That's where they take an image, cross-section through your stomach. Check this out. Please don't pass out. There's no blood on this slide. But you see the cross-section. The person on the left does not have diabetes. The person on the right does. They have intra-abdominal fat, right where those red arrows are pointing. That's a specific fat associated with type 2 diabetes. So when you get that big abdominal area that I just showed you, you might have very little subcutaneous fat. You can't see any here. Everything's below those arrows. And there's this white fat that smothers the organ. It's called visceral fat, intra-abdominal fat. And that's the fat associated with type 2 diabetes. That is genetically determined, and that is impossible to lose from weight loss. So most of the caregivers out there, we try to educate them. You know, don't blame your patients. Losing weight is important, but there's only so much you can do if you have type 2 diabetes, and it's extremely difficult. Okay, let's talk about the toolbox. You see the size of this toolbox? If I was standing next to it, I'd be as tall as the black T under toolbox. This toolbox is huge. I mean, if you look at this timeline, insulin discovered, believe it or not, 100 years ago. And then in 1950 came a class of drugs called the sulfonylureas. Modern sulfonylureas are glipizide and glipizide. Then it took almost 50 years later to come up with the second oral medication, metformin. Now look what happened since 1995 and 2015. We have 9 additional medications for type 2 diabetes. So the bottom line is we have choices now, and that's extremely important. And I'm not going to go through all the different combination pills because there's lots of different combination medications out there to make life easier for you, to have one copay. And there's a drug called Tritergy, if I'm pronouncing that right. These names are tough to pronounce, folks. It's the combination of Jardiance, which is an SGLT2 inhibitor, which I'll talk extensively about, Tradjenta, which is a DPP4 inhibitor, and metformin in one pill. And these are a great way to end up with one copay. Now, the reason why I wanted to tell you all this, because many doctors don't prescribe combination pills, but you could ask him or her because you can save copays, and that's really important. Okay, I'm going to spend most of the time talking about two of the newest classes of medications that are not just for diabetes anymore. They're for heart and kidney disease, and here they are. Ready for this? The GLP-1 receptor agonist. I'm going to tell you what that stands for, but you're not going to remember, but you can go back and do reruns if you want. And SGLT2 inhibitors. Okay, GLP-1. I'm only going to say this once. Glucagon receptor, God, what is it? Gosh, even I forgot it. Glucagon-like peptide 1 receptor agonist. It acts like GLP-1, which is a natural hormone in the body. I'm going to explain that to you. And sodium glucose transporter 2 inhibitor. And what you need to remember is this, that these are drugs that have been around for many years. The GLP-1s have been around for close to 15 years. The SGLT2s, at least 5. And they protect your heart and your kidney. So let's go through the GLP-1 hormone first. Now remember, GLP-1 is a natural hormone that gets released when you eat food. You can see that on the upper left part of the screen. Then it goes down and it stimulates insulin release from your pancreas. Remember, if you have type 2, your pancreas still can secrete insulin with the proper stimulus. And it also leads to, which is not on this slide, glucagon suppression. Glucagon, you don't want glucagon around when you're eating because glucagon raises your blood sugar. Then you can go to the bottom right. It slows down the peristaltic motion of your stomach when you eat. Why is that important? Because when you eat, your stomach breaks down the food, but it doesn't contribute to elevating your blood sugar. It's only when it leaves the stomach, when these nutrients get pumped out of the stomach, that's when it gets absorbed and goes into the bloodstream. So think about it. If you slow down the peristaltic motion of your stomach, then your nutrients get absorbed slower and your post-meal blood sugar is not as high. It also prevents your liver from making excess glucose. And very importantly, on the upper right, it promotes satiety. Satiety means that you get full faster. And in every single study done on 6 of the GLP-1 studies that are available in the United States, people lost a statistically significant amount of weight. And because this medication only works when your blood sugar is elevated, it does not cause hypoglycemia. So I gave you a lot of information, but I think it's important for you to know how they work. Here are all the different ones. Byetta was twice a day. That was the very first one. Then there's Adlixin once a day, Victoza once a day. And then you take these on the lower left, Bydureon, Trulicity, Ozempic. They are once weekly GLP-1s just to make your life easier. And what was recently approved by the FDA, an oral form called Rybelsus. So you can see that we have lots of choices. And I'm going to show you a little later where these drugs are recommended by the American Diabetes Association when they send doctors their different treatment algorithm. Okay, so GLP-1s can reduce the risk of heart attacks and strokes. It's been clearly shown by these big, large, expensive studies called cardiovascular outcome trials. There's been a whole bunch. It's very consistent results. And I want to just say a quick note on this class of combination medications. The two companies, both Sanofi and Novo, made a combination fixed ratio of their GLP-1, Adlixin, and Victoza mixed with basal insulin, Lantus and Degludec. So in one injection, you can give yourself a GLP-1 and basal insulin, one copay. It's an extremely effective way to treat type 2 diabetes. If you're on basal insulin alone and your control is not good and you're not on a GLP-1, this could be something that you could suggest to your caregiver. Okay, here's just a slide with all the different GLP-1 receptor agonists. So this is kind of like a summary slide. Lowers your A1C, leads to weight loss, does not cause hypoglycemia, protects your heart from heart attacks and your brain from strokes. And remember that every GLP-1 is a little different. They have their own set of side effects. The main one for the entire class is nausea when you first take it. But that can be mitigated by starting off on a low dose and titrating the dose slowly. Every one of these GLP-1s has their own titration schedule. So that's important. That's the main clinically relevant side effect. Let's talk about the SGLT2s. These pictures are from Tricia Santos, one of our star faculty members. You can see the heart has the go sign, and then the that's a kidney over there in red, go kidneys. So there are 4 of these. You ready for these names? Farxiga, Invokana, Jardiance, Steglatro. And the chemical name is just to the right. They all end in gliflozin. So these names are killers. But nonetheless, you say them enough and I get used to them. And hopefully you will too by the end of the day. Because almost every speaker that talks about type 2 diabetes does talk about these SGLT2 inhibitors. Okay, let's see. There we go. So why is this class so important? It's a little bit different than the GLP-1s. SGLT2 helps the heart by reducing and preventing congestive heart failure. That's when your heart pumping ability goes down and blood doesn't get pumped out of your heart and you get congested. Congestive heart failure is an extremely serious condition. And if left untreated, you can die. But don't want to get too morbid on the lecture here, but it's important and it's extremely common. And what's recently been shown by these cardiovascular outcome trials and now kidney trials, that if you take someone with poor kidney function, you give them an SGLT2 inhibitor, and it prevents the progression and prevents people from needing dialysis or a transplant. So an extremely important class of drugs. And how do they work? It's a very simple. First of all, you have to remember that when your kidney filter your blood, it filters out sugar. But it doesn't want to get rid of the sugar. It needs the sugar to grab onto toxins. Once it goes through the filtering mechanism of the kidney, it brings back the sugar into the bloodstream. Now, if you have type 2 diabetes, your blood sugar is really high, why would you want to bring the sugar back? You want to get it out of the bloodstream. So that's why the SGLT2 inhibitors prevent the reabsorption of glucose back in the bloodstream. And where does it go? It goes out into the urine. So this drug helps you pee out excessive glucose. A pretty amazing, ingenious mechanism. So you lose sugar, your blood sugar goes down, your A1C goes down, you lose weight. And we have the added benefit of the heart and the kidney. Pretty impressive. And you see the sugar cubes in that guy's hand on the right-hand side? That's the amount of sugar cubes an average person pees out or filters out every day. In a healthy person, it brings it back into the bloodstream. And someone with diabetes out of control, it gets rid of it in the kidneys. Okay, so lowers A1C, leads to weight loss, improves blood pressure, does not cause low blood sugar, and that's another important feature because anybody without diabetes can take these medications. You don't want to do it. It's not really indicated for non-diabetics, but it does not cause your blood sugar to get too low. You can't say that about insulin or the sulfonylureas, where you give someone insulin that's not a diabetic, they'll get hypoglycemic. Okay, and then it protects your heart. Congestive heart failure, and progression of kidney disease, which is common in people with type 2 diabetes. Now, just like the GLP-1s, the SGLT2s, they're different. They're similar, they're more similar than they are different, but it's important that if you're interested in starting one of these medications, if you think you're a good candidate based on what I've said today, talk to your caregiver. What is the most clinically relevant side effect of these drugs? Well, for most people, it's genital. Yep, down there. Mycotic infections, primarily in women, a yeast infection. Because think about it, if you have sugar in your urine, that may cause a yeast infection. So there's ways to mitigate that. It definitely occurs in a minority of people who take this medication. If you're a guy and you're uncircumcised, then you could have a thing called balanitis, get fungus on the end of your penis. If you're circumcised, it's usually no problem. Those are the most important. If you're elderly, you could get a little dehydrated. So once again, please don't go out and take these medications without talking to your caregiver. They know a lot more about these medications than you do. Now, but you might know more than they do at the end of this lecture, and that may be true. I don't want you to read this slide, but I just want to show you. This is what the American Diabetes Association puts out for doctors. And you can see in the upper left, the pink areas, right after metformin, if the person has heart or kidney disease, GLP-1 receptor agonist. Then it talks about, is there concern about the weight? Is there a concern about hypoglycemia? GLP-1s and SGLT2s are right at the top after metformin. And then the last category is cost. And of course, cost is an issue. So when you look at this algorithm, this is what they're recommending. Your first choice after starting metformin. If you are at risk for heart disease, if you have diabetic kidney problems, if you're overweight or obese, or you have a high risk for hypoglycemia, you should be prescribed one or both of these medications. Now, this is just a picture from our website. It's our resource hub. We have information on our website on how you may be able to get these medications cheaper using discount cards, and also to point you towards other organizations that can help with advocacy issues. Okay, now a couple more important concepts. Type 2 diabetes is a polypharmacy condition. I mentioned that in the beginning. What does that really mean? It means that if you have type 2, because of the relationship with blood pressure, cholesterol, heart disease, glucose levels, obesity, you're going to be on a bunch of medications to help control each one of those conditions. That's the most important message. It's not how many medications you're on, it's if your conditions are under control. So you might be on 2 or 3 medications for your diabetes, injectables, orals. You might be on 2 or 3 blood pressure medications. You might be on medications to reduce your LDL and raise your HDL. You might be on an aspirin a day, a baby aspirin, because your doctor wants to protect you from your blood clotting. If you have type 2, you might have obstructive sleep apnea. Very common. You're going to be on a CPAP machine. And if you're a guy, you might have erectile dysfunction. And believe it or not, we got great medications for those as well. And some of the better ones are now generic. So you can get them at Costco. 30 tablets of a pretty good ED drug for $20. And don't be selling them on eBay. You get a lot of money for those. Now, the other concept is this concept, extremely important. Type 2 diabetes may progress over time, and your therapies may change over time, even if you're doing everything right. In the beginning, you might be started on metformin, other oral medications. You might need a GLP-1 receptor agonist. You might need the addition of a basal insulin. That's covered, a lot of the insulin therapies are covered in a different lecture by myself. And if you've had type 2 a long time, you might need to be treated just like someone with type 1 diabetes, multiple daily injections, and or a pump, insulin pump, with a continuous glucose monitor. And we call that the natural progression of type 2 diabetes. So remember that when your caregiver says to you, hey, Mrs. Wilson, you're going to need another medication because your A1C is slipping up a little bit, and you've been trying your best to do everything right, please don't take that personally. And this is part of this natural progression that I just explained, and it can happen over the years. What about home glucose monitoring? Probably one of the most important tools we have to take and stay in control of our diabetes. Lots of good meter companies out there. The one thing that bugs me as someone living with diabetes, why are these numbers on the advertisements always so normal? I don't get it. I would love to have them advertise meters that look like this. Then I would say they really know what we're going through. And then little voices, I put a little speaker box, son of a, or damn, maybe a song. Now, I know some of you young folks out there, you never heard of that song, but it's awesome. Okay, now, Schaefer Bader has given a lecture that's in our library on continuous glucose monitoring for people with type 2. I can't tell you how invaluable they are. You know, the Dexcom G6, the Libre 2 is out now. There's an implantable one called the Eversense. And they tell you your blood sugar every 5 minutes. They give you alerts and alarms. Now, these you can get now, especially if you're on insulin, 3 or more injections per day. Medicare pays for them. So I would just say this. I'm not going to take up too much more time, but any way you can get a continuous glucose monitor, you'll learn so much about your diabetes. It'll be unbelievable. Now I'm going to give you a taste on the newer insulins. I gave an on-demand lecture on how to use the different insulins if you have type 2. Please go look for it for a more in-depth, but I just want to tell you why there's never been a better time to have type 2 diabetes. So we have faster acting insulins. We have Fias, faster acting aspart, and we have Lumjev. One's made by Novo, the other one made by Lilly, and they work faster and they get out of your system faster. Why is that good? Better postprandial blood sugars, less delayed hypoglycemia. What about inhaled insulin? Afrezza is very rapid on, very rapid off. Obviously, you don't have to take an injection. You just hold the little inhaler up. The doses are, there's a lot of information you need to know about the different doses and how to use it. It's actually quite easy, but I just want to let you know that this inhaled insulin is not used enough in people with type 2 diabetes. I'd say the number one reason is doctors don't know about it. So bring it to their attention if you'd like to try it. And we have newer basal insulins. Basals are the long-acting insulin. The older basals are Levemir and Lantus. And even older than that, NPH. And these last more than 24 hours, so they're all once a day, any time of the day, very flat curves. That's what you want out of a basal insulin. Now, what about treating hypoglycemia? I mentioned that in my initial outline. This is one of the old kits that are just so archaic. Oh my God. The poor person trying to put this thing together, has a stroke, and we have much newer ones. We have Baqsimi, which is a nasal spray, and we have the Gvoke HypoPen that you can give either one of them in 5 seconds. Watch the video that Jeremy and I did on our website that goes through this in more detail. Once again, lifestyle modification is so important. No drug can help your diabetes if you're eating anything you want at any time and never exercising and eating candy and stuff all day. Listen, I like sweets. I use it in moderation. I try to adjust my insulin dose for that. I try to adjust my exercise. But we have so many good dietitians and exercise physiologists as part of our video library. So that's important. So I'll give you my take on the diabetic diet. Here it is. There's no such thing as a diabetic diet. There's no magic diet or diet pills. Please don't fall for that crap you see on television. There's no shortcuts. If you lose weight super quickly, guess what? You're going to gain it back super quickly. Weight loss is tough. I talked about that in the beginning. Make small changes slowly. Eat the foods you like in moderation. That's the key. Like, for example, you look at some of these foods. How many of you out there have heard that cinnamon helps your diabetes? Well, I eat 3 Cinnabon a day. Hasn't helped my diabetes at all. But look at the sugar in the stuff we eat. I mean, it's crazy when you don't pick out diet drinks, because it's wasted calories. That's so much sugar, and it just wrecks your diabetes. Let's talk about exercise. Does anybody see anything wrong with this picture? Gee, I know you're all going, gee, there's no one on the steps. Well, I want to tell you about my grandmother. Okay, my grandmother started walking 5 miles a day when she was 60 years old. There's a picture of her. Her name is Lucy. Now she's 100. And we don't know where the hell she is. You know how hard it is to give a lecture without hearing you laugh? It's so difficult. I know you're cracking up at home. Okay. So the bottom line is, to be serious, you got to find out you got to do what you enjoy. Please don't join an expensive health club and then go for the first couple of weeks and then never go again for the next year. But you got to get some motion. Walking is such a good exercise. So I'm not going to get into it anymore, but it's so important. So I'm going to finish up with 2 scenarios. This is years ago when Mrs. Wilson got type 2 diabetes. Here's the first video. Hello, Mrs. Wilson. I have some bad news for you. You're diagnosed now with type 2 diabetes. And in addition to that, your blood pressure is super high. Your cholesterol levels are out of whack. You've got to lose some weight. Okay, now let's go to modern times. Check this out. This is the way it is right now. Hello, Mrs. Wilson. Great news. Your labs came back. We identified some abnormalities that when we get them under control, it's going to make you live a longer and healthier life. And that's your blood sugar, your blood pressure, your cholesterol. And guess what? You get the whole family involved, they will live a longer and healthier life for it too. Congratulations. So long, nation. So remember, buddy, getting type 2 diabetes, taking care of it, will help you live a longer and healthier life. No question. So thanks for watching. We'll talk to you later.